Hi, this is Kathleen. Going to talk a little bit about lipid abnormalities, and then over in class we're going to be doing multiple case studies. So the evaluation and management of lipid abnormalities have to do with, if you talk about the pathophysiology, they have to do with chylomicron transport. And basically the chylomicrons are ingested triglycerides and cholesterol that get transported from the intestines to the liver or adipose tissue via the lymphatic system. The fats, triglycerides and cholesterol, they're absorbed in the epithelial cells of the intestine, formed into chylomicrons and excreted into the lymph. The chylomicrons enter bloodstream at the liver, at the hepatic duct, and transport triglycerides to the liver and to adipose tissue. In the adipose tissue, the chylomicrons have triglycerides absorbed as glycerols and fatty acids for storage. In the liver, the chylomicrons are absorbed and triglycerides are packaged as very low density lipoproteins for transport to body tissues. The very low density lipoproteins is 56% triglycerides and 10 to 15% cholesterol. The very low density lipoprotein delivers triglycerides to body tissues. Once triglyceride content is reduced to 30%, they are called intermediate density lipoproteins. Once the triglyceride content is reduced to 15%, they are called low density lipoproteins, and they lose two peripheral protons, the APOC and APOE, which allow it to bind for reuptake by the liver. Because LDL does not have these two peripheral proteins, or receptors if you will, it has a longer half-life in the blood, and it is able to deposit into areas it should not be in, like blood vessels, especially at higher concentrations. So I'll repeat that again. Because LDL does not have these two peripheral proteins, these receptors, it has a longer half-life in the blood and is able to deposit into areas it should not be in, like blood vessels, especially at higher concentrations. Remember that the LDL delivers cholesterol to tissues. The HDL collects cholesterol from tissues and peripheral cells to transport to the liver for excretion in the bile. When HDL is low, cholesterol accumulates in the endothelium. So that's enough of that patho. I'm sure that's all review for you guys. When we talk a little bit about risk factors, patients who are at risk for high cholesterol are those who smoke cigarettes. Individuals who smoke cigarettes have an increased risk of developing clots in the blood. They also have an increased risk of triglycerides. They have a decreased, most likely, HDL levels, and they have damage to the lining of the blood vessels. The diets high in saturated fats, which are primarily found in animal products like dairy and meat, are also found in palm and coconut oil, causes increased cholesterol. Sedentary lifestyle, exercise increases HDL. Genetics, rare mutations that can result in faulty A protein receptor or enzyme causing a particular pattern of dyslipidemia. When we talk about receptors, we just talked a little bit about the pathophysiology of LDL. And if these receptors are deficient or not available in genetics, then these patients are oftentimes the ones we're screening who have very high triglycerides and or cholesterol that need a specialist. Excess alcohol raises triglyceride levels by increasing liver synthesis of triglycerides, also a major source of excess calories that get turned into fat. Obesity causes multiple things, Endocrine disorders like hypothyroidism and diabetes, both are related to hyperlipidemia. A screening test like TSH and fasting glucose should be done when abnormalities and lipid profiles are discovered. Patients should be euthyroid before initiating meds for dyslipidemia. That means we want to make sure that the TSH is within normal limits. Renal or nephrotic syndrome. Kidneys excrete protein in urine, and increased levels of LDL and very low density lipoproteins are found in blood. Mechanism is really unknown. Hepatic disorder. Liver excretes cholesterol, and bile also makes very low density lipoproteins in HDL. Some immune disorders cause increased inflammatory response, leading to excess lipid mediators. And stress causes an increase in cortisol, leading to increased blood glucose levels. Medications can cause secondary dyslipidemia. Culprits include glucocorticoids, estrogens, thiazide diuretics, alpha blockers increase HDL, beta blockers decrease HDL and increase triglycerides, and protease inhibitors used in HIV treatment can cause hyperlipidemia. This is just a graph that I like to use to talk a little bit about the health disparities between different ethnicities and race. If you look here, this is non-Hispanic white, non-Hispanic black, and Mexican American. These are the mean serum total cholesterols, 205, 202, 201, and 202. As you can see, Mexican Americans went down and then kind of steadied and then went up again. So they haven't really shown a significant decrease in mean serum cholesterol. But when we talk about genotypes and so forth and what works and what doesn't, this is going to be the future of, trying to modify some of these risk factors for some certain cultures and race. The American College of Cardiology, American Heart Association 2013 guidelines shift the way we think about the treatment of dyslipidemia. The goal of these new guidelines is to reduce the cardiovascular risks using interventions, which are all evidence-based. And in the classroom tomorrow, I'm going to give you a handout that shows you the different, how they use the scale for guidelines. So the new guidelines talk about who benefits from a statin. And there's 4 groups. One group is a history of individuals with cardiovascular heart disease or stroke. Remember, these guidelines are really the secondary prevention of those with atherosclerotic cardiovascular disease. They already have heart disease. These individuals are at high risk and need high statin therapy. Patients with LDL of greater than 190 are also at high risk and require high statins. Patients with diabetes, with no evidence of atherosclerotic cardiovascular disease, but they have diabetes and they age between the 40 and 75 years old, they are also at high risk. Individuals with an LDL between 70 and 189, plus an estimated 10-year risk of arteriosclerotic cardiovascular disease of greater than 7.5. This is a calculated, this is a tool, the tool you can copy here. It's the ASCVD risk estimator, and you plug it in. You should plug it in for all patients and make sure you document in the note. This is going to determine part of the formula of whether or not someone meets the criteria to start on a statin. We want to first manage risk factors like high blood pressure, dyslipidemia, smoking. Remember, diabetes is a disease of the endothelium, and elevated serum C-reactive protein. So when we think about a fatty streak, if you will, These are what you call intercellular lipids and extracellular deposits, which make up the fatty streak. Macrophages are part of this inflammatory process. They absorb lipids, and these are called foam cells. Foam cells are the hallmark of early erythemas, and they just expand. So fatty streaks are found in the coronary arteries, which are the beginning of an occlusion, if you will, within the coronary arteries. And so why am I talking about pathophysiology? The new guidelines want to slow down or stop this process. So by doing that, we want to manage hypertension, we want to manage cholesterol, we want to look at smoking, we want to manage the diabetes, we want to look at the elevated serum C-reactive protein. So these new guidelines are not perfect. They underestimate risks. And this is an example of someone, if you practice prior to these guidelines coming out, you have a 40-year-old white male, non-smoker, non-diabetic. He has a systolic blood pressure of 120. His father died of an MI at 45 years old. This patient's total cholesterol is 310 and his LDL is 180. So his calculated 10-year risk, if you go online and do that link, comes up to 2.4. And we're worried about risks greater than 7.5, okay, right here. So here's someone that wouldn't qualify for a statin, yet he does have risk factors that the calculated, the CV risk calculator does not take into account, and that is his father dying of a heart attack at 45 years old. This is the same one. So also with this, I want to talk a little bit about, before we used the Framingham risk score, which had always been the standard, now we're using the cardiovascular risk calculator. You can download that on your Apple or your Android. This has a big criticism of this risk calculator has a lot of criticism. One is that it overestimates patient risks and some underestimate. The CV risk calculator was done by two physicians who calculated the 10-year risk of cardiovascular events using the new risk calculator in Women's Health Study, Physicians' Health Study, and Women's Health Initiative Observational Study. But what they found was that it overestimated the risk by 75 to 150%. So, what does that mean? That means that a lot more patients are going to be on statins. So we have to seriously take a look at that too. So high intensity statin therapy, daily dose lowers LDL on average by approximately 50%. So the goal is to decrease the LDL by 50%. So everyone's number is going to be different because their LDLs are not all the same. And these are the two medications. You can start off with 20 and go to 40, start off with 40 and go to 80. Also, if you look, what if your patient doesn't fit into like one of these groups that require statins? However, they might need, and we're going to go into this slide coming up, but I just want to, so we did the moderate intensity statin therapy. You have a daily dose, an LDL on average by, this medicine will decrease the LDL by 30% to 50%. And these are the medications that you can prescribe for moderate intensity statins. Low intensity statin therapy, daily dose lowers LDL on average by 30%. And here are the above doses and medications. Oftentimes, this low intensity statin therapy is used for people that have not been able to tolerate the high or moderate intensity statin therapy. What if your patient doesn't fit into this group, like that case study that we just did? okay? However, you're concerned. LDL are greater than 160, so additional factors need to be taken into consideration. It's LDL greater than 160 or genetic hyperlipidemia, atherosclerotic cardiovascular disease in male prior to the age of 55, a score in female prior to the age of 65 years old, C-reactive protein greater than 2, an ABI less than 0.9, and an elevated lifetime risk or an elevated calcium score. And the calcium is related to atherosclerosis within the coronary arteries. So that calcium score correlates with an increased risk of a cardiovascular event. So these new guidelines abandoned the LDL targets. And they used randomized control clinical trials which demonstrated specific statin doses, which we saw for the high intensity, moderate, and low. And the goal is not to achieve LDL targets. The recommendation is to continue to measure LDL levels, but don't target specific numbers. Statins, what drug class for someone who has hyperlipidemia? Statins are the first choice. Statins are the only class to demonstrate decrease in mortality in primary, secondary prevention, and non-statins haven't showed any of this. So high-risk group profit from 50% reduction in LDL with statin. Secondary prevention in adults less than 75 years old. These are the high-risk group. Primary prevention in adults with LDL of 190. Primary prevention in adults 40 to 75 years with LDL of 70 to 189, plus an estimated atherosclerotic cardiovascular score of greater than 7.5. Statins for high-risk group, here they are. Notice that Pravastatin has no generic. So Pravastatin is Crestor and atorvastatin is Lipitor. Statin that are metabolized by cytochrome Y450, they oftentimes have more drug reaction, adverse drug reactions to other drugs. So you want to stay away from, if you can, prescribing those drugs that are metabolized by cytochrome 450. So Pravastatin, if there's no generic for that, but if they have insurance and they have a small copay, this is something that you want to prescribe. Moderate risk group, secondary prevention in adults greater than 75 years old. Primary prevention in adults between 40 and 75 years with an LDL of 70 to 189, plus an estimated risk score of greater than 7.5. With this, it potentially could go to a higher dose. Primary prevention in diabetics between the age of 40 and 75 years of age with an LDL between 70 and 189, plus an estimated risk of greater than 7.5. And this is level A evidence. Also, the drugs that are metabolized by cytochrome 450 are atorvastatin, simvastatin, lovastatin, and Pravastatin is not significantly metabolized by cytochrome 450. Notice that the reduction in the LDL is 36 to 45, which is a pretty good option. And the milligrams are 2 to 4 milligrams daily. So Pravastatin and Pravastatin are not significantly metabolized by cytochrome 450. And they almost reduce the LDL by 49%, where Pravastatin is 29 to 37%. So the take-home point, what is the take-home point? Is get the patient on a statin. If a patient is intolerant of a moderate or high dose of a statin, it is okay to use low-dose statin. Monitoring Statin therapy, recommend ask about any pre-existing muscle symptoms prior to starting a statin. Statin tolerability, myopathic syndrome, those patients that complain of muscle aches, you want to watch them for rhabdomyolysis. And myalgias can occur without elevation in CBK. Rhabdo is uncommon. It only occurs in about 1% of the population. Frequency of myalgias is 2 to 11%. Begins weeks to months after starting statins. And least problematic are the Pravastatin, Pravastatin, and Pravastatin, which is Pravastatin, Lescol, and Crestor. Possible etiology is the inhibition of coenzyme 10 production, which the coenzyme 10 deficiency has been proposed to be a causal relationship between coenzyme A, which is an inhibitor that in statin that induces myopathies. However, the clinical benefit of using this as a supplement is unproven. And statins really impair your ability to make coenzyme Q10. So consider, if they have muscle aches, consider Pravastatin or Pravastatin Monday, Wednesday, Friday, or Tuesday or Thursday. You want to check lipids on Monday, Wednesday, Friday if statin is 3 times weekly. Don't forget to check vitamin D levels. This can cause muscle pain. So monitoring statin therapy, you want to check the aminotransferase at baseline, and repeat only if symptoms of hepatotoxicity occur. In 2012, they removed all of routine monitoring of liver enzyme for statin drug labels. So the FDA conducted 5 previous post-market reviews between 2000 and 2009. And the findings, the statins associated serious liver injury was extremely low. And quote the FDA, we conclude that statin-associated severe liver injury is an extremely rare event and appears to be largely idiosyncratic. FDA recommendations: perform liver enzyme tests before the initiation of statin therapy. Stop statin if liver function if the liver function test is greater than 3 times the baseline. The aniline aminotransferase is greater than 3 times the upper limits of normal. As we're monitoring, we want to recheck lipid panel 4 to 12 weeks after statin initiated, then every 3 to 12 months. If the LDL is less than 40 on 2 consecutive measurements, we need to reduce the statin dose. When patients are on statins, you want to monitor for new onset diabetes. FDA issued new labeling changes for the entire statin drug class. All must carry a warning, reporting of the increased blood sugar and hemoglobin A1C with statin use. Pravastatin. There was a study done by West in Scotland, which was a West of Scotland coronary prevention study. It showed 30% decrease in the incidence of diabetes in patients taking Pravastatin. So type 2 diabetics, statins associated with increased risk of new onset diabetes. No increased risk of new onset diabetes in patients with low risk of diabetes. What if you can't reach a percentage reduction with statin? Can you use non-statins? They're very questionable. The evidence is not showing that they're as good as the statins. So you don't want to routinely use non-statins. So here are some of the non-statins. Ezetimibe is a cholesterol absorption inhibitor. It can be combined with the statin. So there was an enhanced trial which showed the reductions in LDL and an increase in HDL, but the enhanced trial You looked at simvastatin plus ezetimibe versus simvastatin, and there was no change in primary outcome. And they looked at the carotid intima thickness as the outcome. High triglycerides. When triglycerides are greater than 500, the goal is to prevent pancreatitis by lowering the triglycerides. Once triglycerides are less than 500, you want to address the LDL goal and use a statin. We want to reduce cardiovascular risk. So triglycerides and nanobit for triglycerides, a 150 to 199 weight reduction and increased physical activity from 150 to 199. Triglycerides greater than 500 you want to prevent pancreatitis first with non-FOM plus meds. When below 500, address the LDL. Signs and symptoms rarely produce signs and symptoms until untoward event occurs. We identify this by using the cardiovascular risk calculator, which was that link that I gave you. Corneal arcus or arcus sinalis is the appearance of white deposit in the cornea near the periphery, often greater in the superior sectors. It is often indicative of hypercholesterolemia among those under the age of 60. Xanthoma is a deposit of yellowish cholesterol-rich material in tendons or other body parts and various disease states. They are cutaneous manifestations of lipoidosis in which there's an accumulation of lipids in large foam cells within the skin. Screening. Complete lipoprotein profile preferred, fasting total cholesterol, LDL, HDL, and triglycerides. Secondary option, non-fasting total cholesterol and HDL, indirect LDL. If triglycerides are greater than 200 or LDL less than 40, you need to order complete fasting profile. Adult treatment panel, their screening recommends all adults greater than 20 years. We screen every 5 years cholesterol, and this includes a lipid panel. May perform more frequently depending on results and risk factors. So if someone is extremely obese, we would want to check their lipid panel. Routine screening begins at age 35 for men and age 45 for women. Routine screening for younger adults with risk factors for coronary heart disease. Men is between 20 and 35 years, women between 20 and 45 years. Screening should include total cholesterol, HDL fraction. Diagnostic studies for screening is total cholesterol, LDL, HDL, triglycerides. Best not to screen during acute illness as there may be a false increase in triglycerides and cholesterol. If results are elevated, rule out possible causes of comorbid issues, and those are the labs that we need to look at: LFTs, amylase, lipase, basic metabolic panel, renal function tests, UA, TSH, fasting blood sugar, and EKG. Causes of secondary dyslipidemia are diabetes, hypothyroidism, obstructive liver disease, chronic renal disease, drugs that raise the LDL and lower the HDL. And those are anabolic steroids, corticosteroids, and hormones, estrogen. We're not going to worry about this. We're going to worry about, so don't worry about those two slides. Statins, the drug of choice, especially in patients with coronary artery disease. You want to dose this at bedtime because the liver synthesizes cholesterol at night. And remember that the reduction in LDL and triglycerides depends on the patient, the dose, and which statin has been chosen. Major actions: reduction in LDL 18 to 55%, and triglycerides 7 to 30%, and they raise the HDL 5 to 15%. These are commonly used statins in doses. Side effects: a myopathy may produce muscle symptoms, rhabdomyolysis. Myopathy is rare but serious adverse reaction to statins, which can range from mild myalgia to severe muscle breakdown or rhabdomyolysis. Mild myalgia, you want to check the CBK. You want to continue to monitor for muscle breakdown. I would not discontinue the drug unless there's an elevation in CBK. If CBK is elevated, the drug should be discontinued and patient monitored for potential renal complications. If no symptoms, it is not necessary to monitor CBK. LFT should be drawn at initiation of medication and monitored every 2 to 3 months for the first 6 months and then every 6 to 12 months. More frequently when the dose is being increased. Elevation in LFTs of 2 to 2.5 times normal during therapy. Treatment should be changed and sources of comorbid liver toxicity, such as alcohol ingestion, should be excluded. So, you don't want to make sure you don't miss that or say they didn't strike you as that, but they have elevated liver tests. You might want to have that conversation with them about alcohol use. All-cause mortality with statins was reduced by 13% in patients taking 40 milligrams of simvastatin compared to placebo. Major vascular events were reduced by 24%. Coronary death rate was reduced by 18%. Non-fatal MI and coronary death was reduced by 27%. Stroke was reduced by 25%. And cardiovascular revascularization by 24%. This was a heart protection study of cholesterol lowering with simvastatin, and it included 5,963 patients with diabetes. The statin-approved indications and recommended starting doses. So this slide, I want to talk about the beta lipoproteinemia, which is also a remnant removal disease. It's a rare lipid disorder characterized by high levels of blood cholesterol and triglycerides. The cholesterol levels usually range from 300 to 600. The triglyceride concentrations are usually greater than 400 and may exceed 1,000. The disorder presents because of a decreased ability to convert very low density lipoproteins and intermediate density lipoproteins to low density lipoprotein particles in the blood, and because of a decreased clearance of chylomicron remnants. This is genetic. So it's again that problems with unable to clear the chylomicrons. And this is a genetic. And remember that these patients have cholesterol levels from 300 to 600, and usually triglycerides are 400 and may exceed 1,000. Bile acid sequestrants, examples are cholesterol, which is 4 to 16 grams, cholestyramine is 5 to 20 grams, and cholesterol is 2.6 to 3.8 grams. The mechanism of action is they bind to bile acids in the GI tract and prevent them from entering circulation. Safe for use with lipid-lowering agents, safe during pregnancy, will interfere with absorption of other drugs, so you need to watch that, and need to space dosing times. May produce GI side effects. A lot of patients don't like it because of the GI side effects. Major action is reduce LDL of 5 to 15%, raise HDL 3 to 55%, may lower triglycerides, contraindicated when triglycerides are greater than 400. Side effects are GI symptoms, constipation, diarrhea, and increased flatulence. Therapeutic benefits: reduce major coronary events, reduce cardiovascular heart disease mortality, and this drug also can decrease the absorption of other medications, so be very careful when you prescribe this. Niacin works on LDL, HDL, and triglycerides. It may produce GI side effects. You want to start with a low dose Slowly titrate dose adjustments. Monitor lipids, glucose, and LFTs. Monitor INR if patients on Coumadin. There are side effects such as increased uric acid, glucose intolerance, liver toxicity are rare and usually dose-related. This can be blunted by the use of sustained-release formulations. You need to work with patients, especially if you are deciding to increase their dose. Gradual increase to mid-range dose of 2 to 3 grams a day in divided doses, and pre-treat with aspirin. This can be an effective and inexpensive option. Pre-treatment with baby aspirin, 81 milligrams, 30 minutes prior to niacin can prevent flushing side effects. You want to monitor LFTs at baseline in every 6 to 12 weeks for 1 year, then as needed. With Coumadin, you want to follow up INR carefully until dosing and INR are stable. So the side effects are flushing, high blood sugar, high uric acid, GI distress, and watch for liver toxicity. It can reduce LDL between 5 and 25%, lower triglycerides from 20 to 50%, and raise HDL 15 to 35%. Contraindications are liver disease, severe gout, active peptic ulcer disease, arterial bleeding, and pregnancy. Precautions are concomitant anticoagulations or dilators may interact with Coumadin and nitrates. Patients who are diabetics, high alcohol consumption, history of liver disease, gout, chronic kidney disease, and unstable angina. You can prescribe niacin immediate release or niacin extended release. So the immediate release, you start at 100 milligrams TID. The maximum is 4,500 daily, and it's 1,500 milligrams TID. Extended release is 500 milligrams at bedtime, increased by 500 milligrams daily every 4 weeks, and the usual maintenance is 1,000 to 200 milligrams at night. Fibric acid, greatest impact on HDL. Generally well tolerated. Major actions are lower the LDL by 5 to 20% with normal triglycerides. May increase LDL when patients have an increased triglyceride level. Normally it lowers triglycerides 20 to 50% and raise HDL 10 to 20%. So side effects are dyspepsia, gallstones, myopathy. It's contraindicated with those with severe renal disease or severe hepatic disease. Commonly used drugs and doses are Fibril, fenofibrate, and clofibrate. And dosing, some are BID, some are daily, and some are, again, BID. Evaluation and management of lipid abnormalities. Other agents, Zetia inhibits intestinal absorption. This is typically prescribed along with the statin. Take once daily with food. It decreases level of cholesterol and LDL. Vytorin is a combination of simvastatin and Zetia. It's one drug. Metabolic syndrome. So syndrome X has to do with individuals with insulin resistance, dysmetabolic syndrome, multiple metabolic syndrome, and there are a cluster of risk factors that these patients present with: high lipidemia, hypertension, impaired glucose tolerance, central obesity. Affects over 40% of persons over the age of 60 years. The ability of insulin to stimulate glucose disposal varies at least 6-fold in apparently healthy individuals, and approximately 1/3 of the population that is most resistant to this action of insulin is at greatest risk to develop a number of adverse clinical outcomes. So what happens is that insulin-resistant individuals are unable to secrete enough insulin to compensate for the defect in the insulin action. And this was the first clinical syndrome identified as being related to insulin resistance. 3 or more of the following risk factors are fasting blood sugar greater than 100, abnormal 2-hour glucose tolerance test, 140 to 199, in HDL, men less than 40, women less than 35, triglycerides greater than 150, abdominal obesity, men greater than 40 inches, women greater than 35, blood pressure 135 or 85 are on pharmacotherapy for hypertension. So if individuals who have blood pressure 135 or 85 and are on blood pressure medicines, they are also fit the metabolic syndrome. So other factors: overweight, obesity, physical inactivity, high carbohydrate diet, smoking, ETOH intake, age, race, and a history of diabetes. Risk factors. I'm sorry. And also, when we go back to who's at risk, American Indian have a predisposition, a genetic predisposition. African American, Hispanic, Asian, they have an increase of cortisone, which creates this inflammation that makes them more, that they found a lot in individuals with metabolic syndrome who are American Indian, African American, Hispanic, and Asians. Also, patients who are on atypical antipsychotics oftentimes have metabolic syndrome. So metabolic syndrome is linked to many things. I'm going to talk specifically about prothrombotic state, which is the plasminogen activator inhibitor, which correlates significantly with insulin resistance. This elevated level of plasminogen activator inhibitor reflects impaired fibrinolysis, an impaired endothelial function, and increased tendency toward acute arterial thrombosis. Insulin resistance also affects other coagulation factors, including plate aggregation, platelet adherence, levels of factor 7 and factor 8, tissue plasminogen activator, and fibrinogen. A pro-inflammatory state, inflammation plays a major role in atherogenesis. C-reactive protein is a marker of inflammation that has been found to be independent cardiovascular risk factor and is an independent marker of insulin resistance. It has been found that CRP levels in cytokines, tumor necrosis factor, and interleukin-6 are increased in patients with metabolic syndrome. Microalbuminemia and metabolic syndrome has been found secondary to the effects of insulin on renal hemodynamics. People with high levels of insulin in their body, it was found that this causes renal vasodilation, which results in increased blood flow, increased glomerular hydrostatic pressure gradient, increased GFR. The localized elevated pressure in the glomerular vessel is involved in increased microalbumin secretion, and microalbuminemia is a strong predictor of cardiovascular morbidity and mortality. Increased uric acid increases the uric acid concentration, commonly seen in association with insulin resistance, hypertension, and dyslipidemia. Studies have found that uric acid concentration is increased in individuals with higher insulin levels, higher insulin response to glucose changes, higher triglyceride levels, lower HDL cholesterol levels, and higher blood pressure. Researchers have speculated that insulin resistance is correlated with decreased urinary clearance of uric acid. Metabolic syndrome, here's the insulin resistance. Here is visceral obesity, which causes free fatty acid, which affects insulin resistance. And this is what happens. And I went through all of that, all of these, if you will, in my last slide. So here are some diagnostics that we use for metabolic syndrome. The book and some articles talk about euglycemic insulin clamp technique. I've never seen that done, but it's there in the book, and it's one way to determine metabolic syndrome. BMI and waist to hip ratio, glucose tolerance test, fasting blood glucose, fasting lipid profile, and urinalysis for protein. Therapeutic interventions are reducing underlying causes, weight loss, increasing exercise. We want to treat associated lipid and non-lipid risk factors, hypertension, thrombotic state, atherogenic dyslipidemia. Basically, that means that we have to do these patients need specific studies to look at arteries? Do we need to look at certain CAT scans to look at their vessels because they have metabolic syndrome and we're concerned about atherogenesis? Foods to avoid: high fructose corn syrup. There's a movie called Fed Up. I watched it last year. Dr. Rocha had a presentation of Fed Up at the Whaling Museum. And it really, when we talk about our society and how much high fructose corn syrup, if you watch that movie, it's a documentary. It's good. It's long, but it's very, very good. So we have to change, and we have to encourage and motivate and multiple times talk to patients about changing their diet and the contents of their diets to kind of avoid adverse effects of this hyperinsulinemia that is caused by high fructose corn syrup, refined sugar, flour, high intakes of carbs, salty food, high fat foods. So we want to correct the following, which we talked quite a bit about. Nutritional recommendations of bread, cereals, fruits, vegetables, dairy, fish, poultry, fats, oils, olive oil, Mediterranean diet type foods. Indications for referral are those individuals resistant to therapy, dietitian referral, with which you really want to get them to a nutritionist right away. Psychologists, a lot of patients may be depressed and that's why they're overweight. So make sure that you address that. And physical therapists, especially if they're inactive, and physical therapy could help with developing an exercise program that's safe for your patient. Strategies, we're going to look at the role of lipids and related markers. I'm going to give you in class a handout of the different lab work that we're going to do that is specific to increase risk of certain lipoproteins and the size, low density lipoproteins, the particle size, and high sensitivity C-reactive protein, which is different depending on your institution. We don't normally do the high sensitivity C-reactive protein. Some of you might, but this one is very specific. So the C-reactive protein, this protein is produced by the liver in its response to systemic inflammation. This highly sensitive C-reactive protein test is needed to detect low levels of CRP that may be seen in vascular and/or systemic inflammation. CRP used to be reported as elevated if greater than 8, which would signify acute inflammatory illness. The C-reactive protein high sensitivity is 10 times more sensitive. So HDL particle size and quantity. When we look at the Boston Heart, which is going to show you the homocysteine levels, the other markers that are used to determine who's at risk. especially individuals that don't meet the criteria for statins, but you draw some of these bloods and it shows, their lipid ratios, they're at an increased rate based on APOA1 levels, and these are levels in the HDL particles. And then there's also inflammation tests, which are high sensitive C-reactive protein, which are very, very sensitive. So if you have someone who has 4.7 high sensitive C-reactive protein, they're at high risk for cardiovascular event. These are inflammation markers. Markers will not spell right. And again, this is on the Boston Heart Diagnostic order sheet that you really want to check in your practice to see if they actually if they order these. If you work in a cardiologist office, most likely they have this. At St. Luke's, they have C-reactive protein. We do have high sensitive C-reactive protein. We don't use that a ton unless the cardiologist tells us to. Lipoprotein-associated phospholipase, A2 or LPPLA. Again, this is on the Boston lab sheet. This is an enzyme produced by the monocytes, macrophages, that break down phospholipids. Increased blood levels associated with increased atherosclerosis. High risk of those individuals greater than 235. So say if someone had this drawn, they didn't meet the criteria to get a statin, but they had this, and they had other risk factors, you'd start them on a statin. Health promotion, weight loss, counseling on nutrition, harmful health behaviors. And the new guidelines, the new American College of Cardiology guidelines, American Heart Association, I'm going to give you 10 questions right now, and I'm going to go over them with you to look at the treatment focus. What do they look at? They look at lowering risk of heart disease, revising target LDL, increasing levels of HDL, or targeting treatment goals in adult patients. And the answer is lowering risk of heart disease. New guideline questions. The new guidelines recognize that superior treatment results may be achieved by lowering dose of statin combined with diet change, promoting specific lipid level goals, lowering dose statins, which also lower the risk of diabetes and myopathy, and more intensive treatment with statins. More intensive treatment with statins is the answer. The new guidelines differ from previous guidelines in that they are more extensive and detailed. Their focus is on whom to treat, what to treat, and how intensively to treat, especially in the treatment of males ages 55 and older, by proposing different treatments for men and women. And the answer is in that they are extensive and detailed. The new American College of Cardiology, American Heart Association lipid guidelines does not address physical exercise, heart-healthy diet, pharmacological treatment of high triglycerides, tobacco use, and it's the pharmacological treatment of high triglycerides. The characteristics of the four major groups of patients for whom statin treatments outweighs the risk include all except a 7.5% 10-year risk of atherosclerotic cardiovascular disease, an LDL of 70 to 189 without diabetes, a primary LDL level of 120 to 189, type 1 or 2 diabetes between the ages of 40 and 75 years of age with LDL of 70 to 189, and evidence of atherosclerotic coronary vascular disease as defined by acute coronary syndrome. And its primary LDL levels of 120 to 189. Which statement about the cardiovascular risk calculator is accurate? It has been prospectively tested for accuracy. It may underestimate risk. It is consistent with best medical practice, likely to be updated in the future. It may underestimate risk. High-intensity statin therapy is not recommended for high-risk patients. It's not recommended for patients with previous MI. It's helpful in reducing the severity of developing myopathy. It's designed to reduce LDL by more than 50%. And the answer is designed to reduce LDL by more than 50%. A patient who does not qualify for one of the 4 major risk groups should be offered a statin therapy if he has a primary LDL of 160 or greater, high sensitivity of C-reactive protein of 1 milligram or less, coronary artery calcium score of 175 units or greater, or an ankle brachial index less than 1.5. And it's a primary LDL of 160 or greater. All patients starting statin therapy should receive each of the following except a thorough history and physical, liver function studies, renal panel, education and lifestyle modifications, or CK levels. And the answer is CK levels. Lab tests for a patient on statin therapy at risk for adverse muscle events should include LDL cholesterol levels, CK levels, hepatic function panel, and lipid panel, and its CK levels. Which diagnostic test is ordered when a patient on statin therapy experiences unusual fatigue, abdominal pain, and dark urine? It's a liver panel. The statin dose of a patient with hepatotoxicity can be addressed if 2 subsequent readings of LDL are less than 40. Urine myoglobin indicating statin intolerance is one sign of rhabdomyolysis, myopathy, myalgia, or myopathy, and myositis. And the answer is rhabdomyolysis. Which is a predisposing condition for statin intolerance? Hyperthyroidism, hypothyroidism, hypercalcemia, hypocalcemia. It's hypothyroidism. When symptoms of statin intolerance resolve, restart the patient on his regular statin dose once a week. Wait for 4 weeks before restarting the patient on his regular statin dose. Start the patient on a lower statin dose 2 to 3 times a week. Use alternative methods of reducing cholesterol. And the answer is start the patient on a lower statin dose 2 to 3 times a week. The new guidelines point to which statin treatment for a non-diabetic 45-year-old male with total cholesterol of 270 who smokes, is not on antihypertensive, and has a 10-year atherosclerotic cardiovascular disease score of 12.5. And the answer is, some of the answers are high intensity, moderate intensity, low intensity, no statins, and the answer is high intensity. The new guidelines point to which statin treatment for non-smoking, non-diabetic, 46-year-old black female taking antihypertensive with total cholesterol of 240 and a 10-year risk score of 4.5. High intensity, moderate intensity, low intensity, or no statins? And the answer is no statins. So that ends it for me. If some of you don't understand those questions, you have to go back to the reading, because those questions come from, the 10 questions come from the readings. And when we go over the case studies, redo these questions, especially before the exam, but also redo them again because they'll make more sense, especially if you really weren't paying attention to the reading, which oftentimes I do. But go back and look at the readings. You should be able to pick up in those readings some of the answers to the questions. All right, see you in class.